Everyone should be joining now. And it's recording. Fantastic. So I'm going to kick off, and as is always the case with these things, people will continue to arrive throughout. And we've got about 30, 40 people on the call at the moment. I'm sure that number will steadily increase. Thank you all for joining this Safety for All webinar, and thank you for joining us on your lunch breaks. The webinar will be recorded and posted online, as are all of our webinars, in case you need to drop off or you'd like to share the content afterwards. And without further ado, I'd like to hand over to Dr. Kevin Hambridge from the University of Plymouth.
Hello, yeah, thank you very much for inviting us along today. So people who have been involved in this research project are myself, Dr. Kevin Hambridge. I'd like to introduce you to Matt Carey as well, and also to Francis Thompson, who played a really important role in getting this study going. So what the study's been about is we've been surveying to investigate violence and aggression that's been sustained by nursing and midwifery students in a UK university. Okay, I'm ready for the next slide, Joss. So the background to all this was the fact that it's known historically that nurses do suffer from verbal abuse. And in some studies dating back about 20 years or so, up to 90% of them have suffered some sort of verbal abuse during their life. And when we look at physical abuse, again, there's plenty of data to show that, maybe up to about 80% of nurses during their career suffer some sort of physical abuse. We know that has psychological effects. So that's been talked about by Edwards in a systematic review. So we know from suffering this abuse, people have effects afterwards. What we also know is that within nursing and within healthcare professionals, there's a very high level of non-reporting. So for various reasons, people don't report this violence and aggression when it does occur. And the other thing we know as well is the fact that there's a definite lack of support afterwards. So, people have these psychological effects from this violence, but what happens to them next? And they suffer and don't get the support they sometimes need. In the NHS staff survey from last year, it stated that about a quarter of nurses over the past year had suffered some sort of harassment, bullying, and abuse from their patients. But interestingly enough, some of that bullying and harassment and abuse had also come from their manager. So on about 10% of occasions, it come from the manager, and also from their work colleagues as well. So other people working within the healthcare profession. And again, it does affect other people other than just nurses. So the NHS executive report in 2023 showed that at least or more than half of doctors had experienced or seen some sort of abuse in the previous year. And most of that had come from patients or from carers. So we know from the very limited data that is available that's out there regarding nursing students that there is some similar figures and the similar issues that nursing students go through in their clinical placements regarding violence and aggression. But what we did know from doing a search of the literature was that in fact there is very limited evidence in the UK, and that was our kind of rationale really for wanting to investigate this a bit further. Okay, next slide, please, Josh. So the survey that we developed, it was based on the literature review. So the previous work that had been done, and we did have access to some of the surveys and the survey questions that had previously been asked, and we knew roughly what the themes were related to violence and aggression that might be sustained. So we had 37 questions in total, and what we did is we asked the students who were student midwives or nursing students to again report their violence and aggression that they just say in the previous academic year. And we sent this out last June, between June and September, to catch them at the kind of business end of their academic year. So when they'd kind of done at least one placement, probably two placements during that year. We asked for quantitative and qualitative responses. So the questions allowed them to report that. Our population of students that we could access was just over 1,600. So that was adult students, child, mental health, midwifery, and nursing associates. And we had a response rate of around 22%, which sounds low, but actually, if 33 is the standard, we did pretty well to get that response rate. So about 369 of the students responded. And when we looked at the demographics of those students, we found that about 90% or more were female, most were adult or mental health students, and we had equal amounts of students from each academic year. So we're kind of reasonably happy that the demographics of the students who responded were reasonably typical of how nursing students are. Okay, next slide, please, Josh. So the findings that we gathered was the fact that around 54% of the students who responded said they sustained some sort of violence or aggression in the past academic year. And when we wanted to know what type of violence that was, we found that about 90% or more was verbal violence. That was the most common type. And worryingly, about a third of those students who responded, they'd sustained some sort of verbal violence or aggression more than 5 times in that academic year. On most occasions, it was by the patient. So 54% had come from the patients, but there was 11 different types of perpetrator. So we're interested to know who these people were who were being verbally violent towards students. And we found that on most occasions it was the patient, but we also found that it was by nurses they were working alongside. It was by the patient's relatives or carers. It was also by untrained members of staff and also other allied health professionals that they worked alongside in their placement. So in total, there was 11 different types of perpetrators of this verbal violence. We're also very interested to know the gender of the perpetrator, and we found that with the verbal violence, on 75% of the occasions at least, it was a male who was being verbally aggressive. We also looked at physical violence, and we found that of these students who did report violence, 46% of them had been physically had some sort of physical violence or aggression, and we found that on most occasions it would only happen once, but worryingly it had happened up to 5 times, and some students did report over 5 times in that academic year. And on these occasions, again, almost 90% was by the patients, but there was other people who were involved in the physical violence, and this was also carers, untrained members of staff, midwives, nurses, and also the student nurses, fellow nursing students as well. And we looked at the perpetrator, the gender of the perpetrator, and on 66% of the occasions, it was a male who was being physically violent. We also looked at sexual violence. And very worryingly for us, when the results started coming through, we found of the students who had sustained some sort of violence, about 11% had sustained some sort of physical violence or aggression. On every occasion, it was a female student. And on 45% of those occasions, it happened once. But again, worryingly, even though it was small in number, it was still very significant. About 20% had happened more than 5 times within that academic year. And again, on most occasions, by far, it was the patient who was the perpetrator, but there was some instances where, again, it was their fellow workers, and also it was by a carer. And again, we're also very interested to know what the gender was, and we found out on those occasions when it was female students who had been sexually violated, it was 80 or 90% of the time it was by a male. Thank you, Josh. We were very interested in knowing what the causes were. So there's been lots of causes being reported in various studies, and we wanted to know how that related to the UK. And the students could mention more than one factor. So I think they could up to 5 different causes or contributing factors that they saw. So the most common cause that people had mentioned, that it was the person's mental health condition that was a contributing factor towards them being violent or aggressive towards them. But interestingly, on 16% of the occasions, it was a lack of staffing. So that was reported as well in the qualitative part, which we'll mention later on, that they perceived they were in environments where there was too many patients and not enough staff, and that was a contributing factor as to how this type of thing happened. It was also the person's physical health condition, so the multitude of areas where the students were with the physical conditions the patients had, that was a contributing factor towards it. Poor communication within healthcare was a factor, but also factors like the patient being in pain and being aggressive because of reasons like that. But interestingly enough, the other factor was about lack of security measures. So it was quite a small percentage, but there was students who mentioned the fact they felt that there either wasn't enough security, or the security wasn't called when they thought it was necessary. And that does trip over to the qualitative findings that we'll mention a little bit later on. So a lack of security measures was a contributing factor towards it. And also alcohol. So we make an assumption that alcohol was a massive contributing factor towards a lot of this violence and aggression, but actually it was quite a small amount of people who reported that. Thank you, Josh. We're obviously very interested to know what the locations were about where this violence was happening. And in total, there was 11 different locations that have been reported. The most common area was the hospital ward. And if you look at it, the hospital ward, the patient's bedside, nursing station, around 60% or more of occasions, it was in that environment. But it did happen in other places as well. So it had happened to students in hospital corridors. It also had happened to students in the community settings, that's when they visited people's homes. But it also worryingly, it happened on the hospital grounds. We don't know the exact circumstances, but it was outside the hospital building, but in the hospital grounds it had happened in. We're also very interested to know the types of specialties where this has occurred as well. And in total, there was 22 different specialties that were mentioned about where this aggression and violence had occurred. We lumped together medical, so that includes, as you imagine, cardiac care, respiratory, renal, etc. And we found that medicine was the kind of most commonly mentioned area. So 32.5% of occasions, it was at a medical environment. But a quarter was in mental health inpatient settings, a smaller amount in community hospitals, and also the amount of violence was occurring in emergency departments was actually quite small. So again, we made an assumption that was going to be quite a prominent area where the violence and aggression occurred, but actually it was quite a small percentage compared with what we thought it might be. But medicine was the most common area. Thank you, Josh. We're also very interested to know what kind of injuries the students had received. And again, on many occasions, they hadn't received any type of injuries whatsoever, any physical injuries. But the ones who had been physically injured, they listed the types of problems that they'd had. So the most common problems were things like bruising. They've been punched, they've been scratched, they've been spat on, they've been slapped, they've been bitten. There was a few occasions where the student had some cuts happened to them, and also the aggression was so bad that they'd had some kind of ligament damage in their hand, a muscle damage in their leg. One person was hit on the back of the head with an egg, but also people were pinched as well. So those were the common types of physical injuries for the students who did have injuries, even though most students didn't report any injuries. I say we're also very interested to know what the psychological effects were. So we know that had been reported before within nursing and within healthcare. And we knew the fact that anxiety and stress was a major factor. And again, that does link in with those previously mentioned studies that I said. And also a massive loss in confidence. And again, that's been reported within nursing. But students feeling very overwhelmed, feeling very embarrassed in those situations, and feeling frustrated with some common factors that people had mentioned. From me and Matt and Francis's point of view, the interesting finding there again was about students wanting to leave placement. So this got so bad for them, they just felt like they didn't want to be in placement anymore, and that was an interesting finding for us and the way that we're going to deal with all this. But again, students feeling very afraid, being very helpless in that situation, not necessarily knowing exactly what they're going to do, and being unsafe. What we also did was, in the questions that we asked, we put 4 questions in that helps to identify post-traumatic stress disorder. So we put those in. And those are questions along the lines of, in the month following this incident, did you have any nightmares about it? Or in the month following this incident, did you think about this when you didn't want to, and things like that. So we had 4 questions in there. And the principles of that would be that if somebody answers yes to 3 or 4 of those questions, it doesn't diagnose post-traumatic stress disorder, but it gives a good indication that they may have some signs and symptoms of it. And what we found was that 54% or 55% of the respondents did have at least one symptom of post-traumatic stress disorder, be it thinking about it when they didn't, crying about it, having nightmares and flashbacks. But what we did identify is that 30, which relates to 14%, did show some signs of post-traumatic stress disorder on a recognized scale that will help identify it. So that was an interesting finding for us, because that's going to help us in the future work out how we can kind of help people if we do manage to identify this. And the other thing interesting about this was the fact that post-traumatic stress disorder in student nurses and midwives has not really been reported very much before. So it's an underexplored area, and that hasn't been identified with anything before, but on very rare occasions. The worrying thing for us also was about how much of the incidents was reported, and we knew from nurses and healthcare professionals that many of them don't report these incidents when they happen. And what we found was that 62% did report it, but again, worrying for us, about 40% of occasions these incidents weren't reported and nobody knew about them. Things that student nurses did afterwards to get over this was they spoke to their family and friends and got a lot of help from them. Only on a third of occasions, roughly, did they get some sort of debrief afterwards in practice. And on 27% of the occasions, they felt that nothing happened afterwards. So they'd gone through the violence, nothing happened afterwards, and things just carried on. And again, interesting for Matt, Francis, and myself was the fact that only on about 11.7% of occasions did they actually speak to their personal tutor. So worrying for us, these incidents were going on and we may not have known about it because they weren't telling us about it, and maybe there weren't mechanisms coming back to us to know this had occurred. There was 15 different reasons why people didn't report those incidences. The most common reason was the fact that they felt it was a normal representation of the patient and there was no need for them to report it. Worryingly, about a fifth thought that nothing would be done about it, so why should we bother reporting it? And again, 10% of occasions, again, interesting for us at the university, was they were worried about reporting it because they thought it might affect their assessment as well. So that was interesting for us to know. But some were afraid to report it, some were too shy. But overall, there was around 15 different reasons they gave for this 40% of occasions where they didn't report the incidents that had occurred. Thank you, Josh. One of the questions was, did they have enough training, or had they had enough training? And 36% felt they had not received enough training or education about violence and aggression during their program. So that was going to be, that's going to be food for thought for us going forward. As I said, what we did was on the survey, we asked questions and closed questions. We also gave them opportunities on 2 occasions to write some qualitative information and write some comments about their experiences, just to get a better understanding of it. And it came to kind of two major themes. One theme was about their kind of thoughts and experiences. The other theme was about education and prevention, training and prevention. So with the first theme, one thing they did talk about was verbal violence, and they talked about this violence happening again between the patient and the nurse and nursing student. They talked about it from the carer towards the nurse and the nursing student. They talked about it from the nurse or their allied professional against the nurse or the student. And on some occasions, the verbal violence was a nurse against a patient and things like that as well. So they did give us a good window into the kind of verbal violence that was happening out there. What they seemed to get a feel of is that nurses and healthcare professionals thought that the verbal violence was just part of the job. It was a normal thing that happened. They gave some examples of when nurses shouted at students when they asked them a question and the feelings they got about that. There was instances where they'd witnessed doctors shouting at fellow students or nurses, and the kind of feedback from that was is either his way or the highway. So it was like a normal situation for people to be verbally aggressive in certain situations. They also talked about the physical violence that they'd seen, witnessed, and again they talked about when they've been bitten and they've been grabbed by the throat, they've been kicked in the ribs, and they've been slapped, and gave some examples of how that had occurred. They also talked about the sexual violence, and they talked about inappropriate touching, inappropriate comments being made. And again, the examples were given from patients, but there was a couple of occasions when it was people in authority over them, over the student. And again, in those situations, the students talked about they didn't really know what to do in those situations because of that power issue. They didn't know how to report it or if to report it, so it just happened and they just carried on. They also highlighted the patient groups. So like we mentioned before, the patient groups in the examples were people who'd had mental health conditions. It was children in different situations in their life. It was people who'd had suffered from dementia, but it was people who were withdrawn from alcohol. And on some occasions, it was patients who'd previously or had a history of violence in those settings, but on some occasions, the student hadn't been informed of that and hadn't been prepared for that and the problems that created. They also talked about the causes. So again, I mentioned before, a lack of security. Understaffing was an issue they'd highlighted. There wasn't enough staff there to prevent some of these episodes from occurring, and also maybe to deal with some of these as it happened as well. And also a lack of security, like I mentioned before, the fact that there wasn't any security, or there was limited security, or the security wasn't called when the student thought it should have been called to try and prevent some problems from happening. There was also a few comments from some students who were international students regarding racist abuse, and the kind of feeling from them was they'd come to the UK and they'd come to study over here. They were training to care for people in those settings, and they couldn't quite believe that they were now being racially abused in those areas, and they were going through that during their program. The students felt there should be some kind of more support for them. So coming from the university, coming from practice, and coming from debriefs, which they sometimes felt was more blaming exercises. So some of the students who did have a debrief after the violence felt actually it wasn't really helping them to cope in that situation, to move forward in that situation, but more of pointing the finger at them or somebody as a blaming exercise. But the students wanted to know a bit more about policies and procedures, and I said they wanted more support from their colleagues and from us. There was also a feeling from the students that they'd become, and the nurses had become desensitized because of the amount of violence that was happening in different environments, and it almost become like a normal situation in some circumstances, and they've become desensitized to the violence. And also on occasions, the students had mentioned that if a perpetrator had been violent on multiple occasions, there appeared to be in some places a lack of consequences. They say couldn't see the consequences for the person if they had been violent towards them or other people in those settings. But there was felt a need that nursing students and nurses should speak up a bit more about it to make people more aware of it. But students did also mention that not necessarily them, but they did have a feeling that this could be a reason why students would drop out of the program if they'd been through some harrowing experiences with either violence or aggression in their placement. So the second theme relates more to education and training and prevention. And one of the points was the fact that they felt they needed better support in placement, and they needed better support from the university. And a feeling that actually the practice assessors and the academic assessors and the personal students probably need some training in how to support students in these complex situations when they might be suffering the psychological effects of going through this kind of trauma. There was a feeling by some students, not everybody, but there was a lack of training or education, that some people weren't prepared enough for going out into placement and suffering some of the abuse and violence that they did see. And especially in certain groups like mental health students who may be in areas where they may see that a bit more often. And also the kind of training they might like. So they wanted education that relates to, understanding what the roots of the aggression was and prevention strategies and how to try and prevent it. Because they didn't always feel they had all the skills to deal with those situations. They also wanted de-escalation training in a clinical skills environment through different scenarios, and felt the benefits of actually experience it in a controlled, safe way might help them to cope with those situations in the future. And they wanted it to be mandatory. So they wanted it to be very regular, and to have training each academic year, not just as a one-off at a certain point in time. And they also felt that in certain circumstances, learning from their peers would be a good experience. So having some reflective sessions with their peers that they could talk through each other's experiences to get a better understanding of what it was all about and how people coped in those situations. So a lot of qualitative information there as well that came out of the study, which was really enlightening to us. So the kind of take-home messages that we had from the work that we've done was that by doing the survey, we now know that students and midwives do sustain all types of aggression and violence in the UK. And we know that comes from multiple people, but the most common people who would be the perpetrators of this would be patients, but also relatives and carers, but also worryingly their fellow members of staff working in the hospital with them. We knew that because of the 22 areas where this had been reported, it was commonly happening in many different clinical environments. So it was almost as if almost everywhere where students were going on their placements, they had the potential to suffer from either verbal, physical or sexual aggression or violence in those areas. And we know that there's various types of physical injuries that students can have. And I said most students didn't have any physical injuries, but the ones that did suffer with those. And again, the other thing was about the psychological hidden effects. And again, knowing that some students are suffering from anxiety and depression and low mood and wanting to walk away from nursing. But on the other end of the spectrum, there is some students who are having flashbacks and nightmares about this that we may not even know that's happening. We know that many instances like this are underreported. So there's lots of reporting going on of this. But we also know from what the students have said that they need improved support and improved follow-up from this, because this is going on and maybe there's not the right reporting situations coming through that are telling us about this. And what they wanted was more training and improved training and education that would maybe prepare them for their placements a bit more effectively. And this increased awareness of the issue. So the feeling that student nurses feel they should speak out about this more, so more people are aware of this as a factor. So we're just in the process at the moment of writing all this up for publication. So we're hopefully in the next few months there'll be two papers coming out from this. One look at the quantitative data and one look at the qualitative data. So that'll be published with some more details about the study a bit later in the year. We've just started another bit of research as well. So we've also looked at allied health professional students. So we've looked at occupational therapy students and physios, paramedicine, etc. And that survey's live at the moment. So we'll have some more data later in the year looking at that group of students. And again, as I said before, nursing students were, poorly represented in the amount of research that's been done. And we found there's even less on these allied health professional students. But some of the kind of things that have come through so far would be that it's around 20% have suffered some sort of violence or aggression. And most of it so far has been verbal, so about 90% verbal, with a very small amount physical. So that's what we know. That's what we know so far. But as I say, we'll have some more results of that a bit later in the year. So that's the next bit of research that we're going to do. Right. So thank you very much for listening for that. We're open to any questions. I'm not sure the best way of doing this, Josh, is.
Well, first up, I wanted to ask if Matthew and Francis had anything additional to share. Kevin's overview is quite comprehensive, but from your side of the study, if you had any more perhaps anecdotal evidence that you might want to add to what Kevin shared there. Francis?
Matt, you're leaning forward to say something there.
No, to be honest, I think Kevin has covered most things. I think one of the things that was most prominent from my perspective, especially when analysing the qualitative data, was how so much of this, for many of them, was just part of that normal day-to-day practice and accepted by other people in those sort of settings. So it was assumed by the student that this is kind of the way things are, and had to become part of their normal practice also. So again, around that sort of support and knowing where to go for that support, yeah, that was something which definitely became through most prominent from my perspective. Don't know if you agree with that, Kevin.
Yeah, I agree totally. I said the worrying thing was is that a lot of this was going on out in practice and we weren't aware of it, and that's the worrying thing for us. That obviously there's plenty of support and available through the university systems if we can direct these students to it, and further support if they need it. But so the worrying thing was it hadn't been reported and we weren't aware that it was required. So it's opened our eyes a bit to that.
Yeah.
We've had a question in the chat there from Kelly and Joanna about raising issues with the police. And it's something else that's come up in a previous session we've had on violence at work, and where the line crosses between, well, this is normal. Well, it's actually not normal. It's just because it's in a healthcare setting that and dealing with the public that people see it as normal. So where does the role of the police come into it?
Yeah, so I think on a few occasions they had mentioned the police, that they either wanted to bring the police and were told not to, or the police were called in those situations. So I suppose the things for the students in placement, if nurses and healthcare professionals are their natural role models, they are getting mixed messages in different places regarding things like what they should do about that afterwards, you see. So, and I think, like I mentioned before when I talked in London, you know, if this was to happen on an aeroplane, they'd bring the plane to the nearest, you know, airport and the person would get kicked off by the police. But because it's happening in the hospital, what's ever going to happen about that, you know? And you hear about it in the news, don't you? It's a news headline. It's a main headline that it's happened on an airplane somewhere, and everybody knows about it. This is happening every day, every hour in a hospital, and because it's healthcare, what's ever being done about it, you know?
Thank you. A couple of questions about the study as well. The first one is are you able to share this afterwards? And I believe the answer is yes.
Yeah.
And a question from me would be, do you know where you want to publish this?
Yeah, so we're in the process of working out the best route for this. We've got a few ideas, and what we have within the university is like open access journals. So we're thinking it will go into one of those, just to help people to see it more broadly. Really, we don't want to put it behind a paywall where people can't see it, because we think it's so important. We want to put it out to the masses, really. So it'll be an open access journal a bit later in the year, but we haven't quite decided which one yet.
Another question is, do you have a breakdown of data between first, second, and third year students?
So
beyond, I assume.
Yeah, so we haven't gotten to that level of detail, but I mean, all three groups were represented equally.
Thank you. Another question here from Sam Howard says, was there a difference between the educational ask between MH and acute students? In Birmingham, we have a package for student nurses, and there's an expectation that student nurses are provided with some training and knowledge around de-escalation. Were the students also explicit on what the training should look like and its contents?
I can answer the first part of that, Kevin, if you like.
Yeah.
So within our organisation, there are some differences. So we follow the national guidance and package around mandatory training, which includes de-escalation for all students. But mental health students actually get an additional kind of breakaway de-escalation training in a bit more depth, which is actually managed by the host organisations themselves that run that. So there are some differences. And I think the interesting part about it is that a lot of the stuff that came out as Kevin presented was people who had exacerbated mental health problems causing violence, but it wasn't the main area where the violence was occurring in this particular study, which demonstrates maybe that should be extended out to other groups. You want to add to that, Kevin?
Yeah, I agree, and I think really because someone's got a mental health condition doesn't mean they're in a mental health hospital or setting, does it? So there's that crossover. So I think that again, I think more, you know, the students want more training and more education, I think, irrespective of which branch they're on and which field they're in, because they are going to see it. And I said there was some examples of children's nurses with children with mental health conditions, etc., who are being violent as well. So it's not just solely, you know, mental health students. I think it's the whole gamut of every type of student.
Yeah.
Thank you. A question here, I think a point of notice from Henry Tobin. He strongly advises you should liaise with the National Association of Healthcare Security. He's worked with managing these problems within the NHS for years, and there's a wealth of best practice to be learnt and shared, which universities can request. I don't know, Henry, if you'd like to follow up with us after. I'm sure Kevin would be appreciative of an introduction there. A question from Sarah Kelly as well, saying that all of these should be covered by the Emergency Works Law. I'm not sure if you're familiar with that, and she'd like to know if the students were wearing a uniform when assaulted in the hospital grounds. I assume that relates to the law itself.
Yeah, so we didn't have that level of detail to know if they're in uniform or not. So we didn't know that, but we were interested to know just where their locations were. So yeah, we didn't know that level of detail about uniforms.
And I guess not all students wear uniforms in all situations either. So often in mental health context, people will be in smart casual clothes. They'd normally be wearing identification, of course, but not necessarily a uniform.
Thank you. Another one from Stuart here, Stuart McLean. You mentioned both quantitative and qualitative studies, which would be great to see. Do the studies include the issue where people living with a learning difficulty and/or mental health issues need to undergo treatment in an acute setting?
So I don't think that really came across in any of the perpetrators who might have learning difficulties. I don't think that came across with any of the responses. And again, in the university where we did the study, there's no learning disability training within that environment. So again, that may be a future project to try and encompass those groups of students, and it would be interesting to know. It's a good point.
And a couple of comments here, which I think are agreeing with each other. From Paul says, we seem to gaslight our staff and student when incidents occur, directing blame at staff that they may have triggered the event or aggression. I know that there is best practice and guidelines around that, but it's about the culture of blame within the NHS. And I think that comes with a sort of hierarchy of control, as you mentioned as well, Kevin.
Yeah, I think that it did come across that you know, there was a lot of blaming going on during the debriefing session. So they were happy with it having a debrief because many of the students didn't have the opportunity, but some of them felt that actually it was blaming people rather than trying to help them. There was a few occasions where the students felt that health professionals were stimulating the violence. So that was mentioned on a few occasions. They felt that the behaviour of the healthcare professional did stimulate a response from some of the patients and relatives.
And I guess that possibly, I mean, interestingly, possibly links into the stuff that came up about staffing, lack of staffing. If there's more frustration in the patient group around receiving care, or lack of ability for people to support them appropriately, or in their view, that may, I don't know if that came up in the actual conversation, but that's a known factor, I think, in terms of risks.
Thank you. Apologies if there's noise outside. We've got a protest going on outside our window. Apologies if you that.
Is it a protest against you?
Another note from Henry says a glaring gap in prevention is the failure to expand the special allocation scheme, which is formerly the violent patient scheme, to all services. It has been limited to protecting GP surgery staff. He said it's totally bizarre and unjustifiable. The scheme works and should be extended to all healthcare services. Henry is also happy to introduce you to the director of the NHS as well, as you mentioned previously. And then Dan Jones has also asked if the study has been shared with NHS England Violence Prevention and Reduction Programme. I think that there seems to be a lot here about dissemination of the results and the various organisations which would want to see it, which is why I asked about publication. Getting this as far and wide, because there are a lot of organisations that do care about this. We're currently speaking to Unison, the RCN, and NHS Resolution about similar studies. So I think dissemination is a key point, Kevin.
Yeah, so we've done a few presentations like this, and again through the publications, hopefully that will stimulate more awareness and more discussion. But yeah, I think hopefully at a higher level. I've spoken to the RCN about this as well at one point, so hopefully that might be some follow-on work that we're going to do about it as well.
He also says that NHS produces the violence reduction standard, which all NHS providers are contractually required to implement. Would be interesting to see how providers implementing those standards ensure that students are also picked up in those standard indicators. Sorry, if you wanted to comment.
Yeah. I was going to say when I did this presentation with your in December, I think people were absolutely amazed this was happening to students. They'd never heard, they just assumed it was always happening to nurses and doctors and other people, but they hadn't really given a thought to the fact that it could be students who are suffering from this. So I said, hopefully this is going to raise a bit of awareness really for people.
And there's sometimes structural reasons for that, which we've had to address in the past. For example, reporting systems not having drop-down boxes, for example, that capture student. So they've got staff groupings. So things like that can sometimes get in the way of reporting. And I think that came out in your presentation, Kevin, that, staff members, personal tutors not always being aware that it had happened and it being unreported, which is sometimes links to systematic issues as well as people not reporting, if that makes sense.
But that's one of the things hopefully going to come out of this, is the fact that we've made some big strides in, say, if a student has a Sharps injury in practice, there's a better system now for the personal tutors to know about it very quickly. And we're hopefully, when we present this work, there's going to be a better system for violence and to come back to the personal tutor a lot quicker because of the support that's needed for the student. So we're hopefully going to improve some of the systems with this locally.
And a note from Sharon Rhodes there, she said, was the area regionally of England a factor?
Well, the students are spread out over three counties, and it's rural and urban in a multitude of settings. So we're hopeful that it's reasonably representative. But again, like anything else, if it was done in a different part of the country, in a different setting, you may get different types of findings. But the findings that we got were within the ranges, some of the percentages were within the ranges of previous work that had been done around the world. So a lot of the work around the world had been done in Scotland, Greece, Turkey, Asia. So our kind of percentages were within the bands of previously reported findings. But maybe geography could play a part in it, and different parts of the country might have different amounts.
And Henry agrees, saying it's a nationwide problem, sadly. A question here from Sophie about following up after the incidents. Was there anything asked about whether the perpetrators were given any sort of warning or sanction following the incidents?
Yeah, so that wasn't a question that we asked, but again, that was the lack of consequences that came out through the qualitative. So students did mention that sometimes nothing seemed to be done with people who were, who were being violent or aggressive. Some of the things they did mention was the fact that it did sometimes affect the relationship there between them and the patient and the carer if this abuse had happened for a patient they was continuing to care for, because this had now changed the dynamics of that kind of relationship and when it had happened. But I think the main factor that came through was a lack of consequences for some perpetrators of violence, and they couldn't see what had happened to them regarding, I say the word punishment, but the consequences of what had happened.
Thank you. A question here from Stephen Summers of Kingston Hospital, which is my local hospital. He said, is there any data looking at who the perpetrators of the verbal compared to the physical violence were? And he gives an example of a differentiation that indicates boundaries. For example, is it colleagues that favour the verbal abuse, and then it might be patients or otherwise that favour physical violence?
Yeah, I mean, it seemed to be the patient and their relatives were the main perpetrators of each type. But again, the worrying thing for us was there was a whole range of other people to a lesser extent, but commonly they're the students' peers and fellow healthcare professionals who were that. So we have got that level of detail, and when we publish it, we will give that level of detail. But I haven't got it off the top of my head. But we can highlight who was the main perpetrators in each case.
Thank you. And a question from me, because I'm very aware that our audience it's a lot of frontline healthcare staff and people in positions of leadership in hospitals. But what would you say is the best guidelines to follow? Is there a main sort of best practice out there? I know there are lots of different versions of one, but is there one that you would recommend?
Well, this is a bit of a learning process for us, so we can't say we're necessarily experts in that next stage, and that's the bit that we're going to be going into next, because obviously this has raised so many questions for us regarding the education side of the student preparation that we are going to have a really good think about what we're going to plan next and the guidelines and processes we've got to start following for students. And also part of that is also going to be looking at the evidence and working out, and because students want to know more about the policies and procedures, and we need to have a look at the evidence and try and work out what is the best processes for them to follow. So it's going to be a bit of a learning process for us, because again, a year ago we didn't know this was happening, but we are now going to have to really look into this and not just stop because the survey's finished. There's going to be a big follow-on next to try and improve these processes for our students. But it's unknown at the moment because we haven't got to that stage. But we will be looking to that soon.
And I think the good thing about surveying students as well is that the cohort will change. Year on year, so it's very easy to sort of track progress in these things. A question from Dan Jones. He says, were the trusts of which your university places your students able to provide any data around the assaults involving students?
So, I mean, that wasn't part of the work that we'd done, but maybe in follow-ups, that could be something we could look at, which we've done that kind of thing before. And I've done that kind of thing before when I've looked at Sharp's injuries. You're comparing what the students say in a survey and what the data is out there, and looking at that information. So yeah, it's something for and this isn't going to be a one-off study for us. So as I said before, we are going to follow this up in a few years' time again and see what the changes are based on what we've done. But yeah, using data that we can get from the NHS would be a good source.
We do have internal processes for recording incidents which come via our practice partners and our students, and we follow those up with action plans with the host trusts, placement development teams, and learning areas. I think the thing that's most interesting, of course, is this issue that Kevin highlighted in the presentation of actually where we don't know it's occurring. So to speak to Sam's question there is quite a lot of support for students available, both within the standard university setting and through the personal tutor and through the organisations. But of course, if we don't know about it, then there's a gap. So I think that reporting issue is a big one, really.
Thank you, Francis. Henry, again, as just a comment about the previous point we're talking about guidelines. He says the NHS has its national violence prevention and reduction standards, which all NHS employees should be following, and non-NHS employees can still adopt and adapt them. Sam Howes asks if there's a post-incident support offering for students.
I think I sort of just answered that one.
Yeah.
Unless you've got anything to add, Kevin.
Yeah. Yeah, so if we know it occurs, then obviously there's lots of processes through the university that are internal, and we can refer them to external as well. So there's lots of support available regarding their well-being if we know about it, and that's the crux for us, really, because obviously this is highlighted to us that there's a lot going on that's not being reported and we don't know about it, and just trying to improve that reporting part, I think, really, and the systems for us to know about it more.
I think it fits in with other work we've been doing separate to this around attrition risk from programs. So there's lots of overlaps between people's experiences in practice and.
Thank you. And another message from Ingrid Henderson, who said that this fits with our Fair 2 report, which I think I mentioned earlier. She says there is such a need to improve the culture of civility within the NHS, and it's shameful that our students are experiencing violence in their training and not being protected more. Thank you for sharing. And both Ingrid Henderson and Victoria Wilkins from NHS Resolution have asked for follow-ups, so we'll be sure to loop them in. There's no more questions in the chat, and we're coming up to time, so I'd just like to thank Kevin Hambridge and his colleagues Matthew Carey and Francis Thompson from the University of Plymouth for sharing their study. We will be sharing the recording of this webinar along with the slideshow that Kevin had, and of course once the survey is published we'll be sharing that with our network as well. So thank you for attending this Safety for All webinar, and I'll say have a nice day. Thanks, Kevin.
Thank you very much, everybody. Thank you.
Have a nice day. Bye-bye.
Bye.